So there are other ways to kind of reduce or adjust for the quote unquote off phenomenon. We can use a new drug class called COMT inhibitors, and that stands for the enzyme catecholamine O-methyltransferase. And the two main COMT inhibitors include N-tacopone and tolcapone. And these can actually prolong or potentiate the levodopa effect and actually reduce the amount of time in the quote unquote off phenomena or the off time when patients experience a reduction in the efficacy of levodopa. So these drugs actually reduce the breakdown of levodopa itself, and these drugs are generally ineffective when given alone, so they don't really do much. However, when you combine them with levodopa, you get a really nice clinical effect. And so N-tacopone blocks the catecholamine O-methyltransferase enzyme peripherally, whereas tolcapone blocks COMT in both the periphery and in the CNS. So the way I always remember it is tolcapone blocks the COMT enzyme in both places, and so T for total, so total COMT inhibition, and also T for toxicity, because these drugs can be, this drug in particular can be quite toxic. These drugs do increase the plasma half-life of levodopa quite remarkably. The most common side effect to the COMT inhibitors are due to increased dopaminergic stimulation, which can include dyskinesias, as well as psychiatric effects, including mainly visual hallucinations. Nausea, diarrhea, orthostatic hypotension are also common. Both drugs are also known to cause a brown-orange urine discoloration. Tolcapone was removed from the market in Europe and Canada in 1998 after 3 reported deaths from hepatotoxicity in patients using tolcapone. These drugs remain available in the United States, however, with the recommendation that it be used for the treatment of motor fluctuations only after other methods have been exhausted, and the patient must receive regular monitoring of liver function enzymes. The next drug is under the brand name Stalevo. We very seldom mention brand names, but this one is unique in the fact that it's a combination therapy of levodopa, carbidopa, and N-tacopone. And pharmacologically, these drugs are used to prevent the conversion of levodopa into dopamine in the periphery. So that's the mechanism of action of carbidopa, and preventing the peripheral breakdown of levodopa, increasing the bioavailability of levodopa to the brain, and that drug is N-tacopone. This will also help reduce some of the peripheral side effects. The increased availability of levodopa may lead to a smoother and steadier level of dopamine in the brain, which may provide better symptom control for longer periods each day. Yet, high levels of this drug can also lead to dyskinesias. Remember, bioavailability is different than availability. Availability is the amount of drug that gets to the target, whereas bioavailability is the amount of drug that reaches the systemic circulation. The next group of drugs are also indirect acting agonists, the monoamine oxidase type B inhibitors. The main two drugs here are selegiline and rasigline. These are both monoamine oxidase B selective inhibitors, and they increase the plasma concentration of levodopa by reducing its metabolism. They are potential long-term enhancing effects on dopamine transmission because of complete and irreversible inactivation of the enzyme monoamine oxidase type B, one of the main enzymes involved in the catabolic metabolism of levodopa. Selegiline is partly metabolized into amphetamine derivatives, and so you might want to be careful if you have a young Parkinson's patient who's still in the workforce, who might be subject to random drug tests. They actually will test positive for amphetamine, but the clinical effect of this particular amphetamine derivative is basically negligible, but it's large enough that it will show up on drug tests. Rasigline does not metabolize to amphetamine, so it might actually be a better choice for the younger PD patient who's still working. With the monoamine oxidase inhibitors, the most common side effect is going to be nausea and vomiting, as well as headache. Some of them do experience some hallucinations, and so that has to be thought of as well. And there are major dietary restrictions with this particular class of drugs because we can actually produce a unique side effect called the tyramine effect. Here's a chart summarizing the selectivity of all of the different monoamine oxidase inhibitors that are out there. The ones that are used clinically for Parkinson's disease are monoamine oxidase type B specific, and those were the first two that are listed on this chart. Other monoamine oxidase inhibitors will be talked about in other lectures, but for the Parkinsonian patient, we're really only dealing with selegiline and rasigline. Earlier, I made reference to the tyramine effect. This was affectionately known as the Chianti wine, pickled herring, and cheese effect, and we'll show you why that is so in another slide. But basically, tyramine is normally broken down by the monoamine oxidase enzymes. In the presence of an inhibitor, the increased concentration of tyramine can actually result in the release of norepinephrine. Patients will then experience sweating, tremors, dizziness, elevated blood pressure, tachycardia, and we usually did not see this in treating PD patients because the doses of monoamine oxidase type B inhibitors used is much, much smaller than what we use for depression, another clinical indication for MAOI inhibitors. Serious adverse reactions have rarely occurred following the combination use of selegiline with tricyclic antidepressants or selective serotonin reuptake inhibitors, or SSRIs. In practice, however, the vast majority of patients on these combinations are able to tolerate them for years. However, the physician's desk reference, the PDR, warns not to use selegiline with either tricyclics or SSRIs due to possible tyramine effect. And so tyramine can actually kind of occur when patients consume foods that have preserved or dried or pickled components to it. So Chianti wine, pickled herring, a lot of the Italian cheeses and dried meats like salamis and prosciuttos and so forth can really kind of exacerbate this tyramine effect. Another indirect acting agonist, ironically, is amantadine, which, yes, is an antiviral. This drug was made in 1960 to treat certain strains of influenza and was accidentally realized to be a treatment for Parkinson's disease. Its mechanism of action is uncertain. It is known to increase dopamine levels, inhibit dopamine reuptake, and stimulate dopamine receptors. It may also exert central anticholinergic effects. Yet its mechanism of action is uncertain. It is known to increase dopamine release, inhibit dopamine reuptake, and stimulate those receptors positively. Amantadine can help with levodopa-induced dyskinesias and motor fluctuations. The major side effect is peripheral livedo reticularis, which is shown here. Livedo reticularis is a cumulative dose side effect or so for when patients have used this for about 6 months or so and then stop the medication abruptly. It presents as a kind of a lacy, purplish discoloration of the skin and on the legs with some swelling. This relatively rare side effect, of course, Steph likes to talk about it, occurs in less than 1% of people with Parkinson's disease who take this medication. But it's really the only time you'll ever see it, so we cover it here. The last group of drugs are the direct-acting agonists, and these actually stimulate the dopamine receptors. These drugs are true agonists, and they don't require any metabolic conversion. They don't compete with amino acids for the transport across the gut or the brain, and they do not depend on uptake or release within the brain. They do tend to have a longer duration of action compared to levodopa. All the drugs in this category have a much greater selectivity to the D2 receptors versus the D1 receptor or even the D3. Activation of the D2 receptors because it's linked to GI proteins or inhibitory proteins will inhibit the indirect pathway, allowing for movement. Essentially, you are inhibiting the inhibition. All you can see from this table is that the dopamine agonists also have affinity for the D3 receptor, which are typically expressed in the mesolimbic pathway. Agonism of the D3 receptors can often lead to compulsive disorders, which we'll learn about in psychiatry, one of the side effects of dopamine agonist therapy. Yes, some of these patients do tend to develop compulsive gambling addictions. The other adverse effects included by dopamine agonists are similar to those of levodopa, including nausea, vomiting, sleepiness, orthostatic hypotension, confusion, and hallucinations. Treatment with pergolide or cabergoline are associated with an increased risk of cardiovascular disease, particularly valvular heart disease, due to serotonin receptor activation on the heart valves. Pergolide was actually pulled off the market in 2007. Dopamine agonists are commonly used in combination with carbidopa and levodopa to reduce the amount of off time patients experience with advanced PD with motor fluctuations. When the combination works well, the dose of levodopa can actually be reduced. Major drugs in the direct-acting agonist category are listed here: pramipexole, ropinirole, and cabergoline.